So welcome everyone to today's meeting. We are happy to be joined by Dr. Moses Kamya, but we'll take a few minutes to wait for a few people to streak in, and then we'll kickstart this presentation. Thanks so much for giving us your morning for this talk. Once again, thanks for joining. We are waiting for a few people to streak in, and Dr. Kamya is already here. We will be starting this in about 2 minutes. Thank you, and good morning.
How is the weather like in Seattle?
It's been actually great. Yesterday was beautiful, but spring Seattle times sound very unpredictable. A few days ago, it was the opposite, but it was fantastic yesterday. Overall, great. I think we'll get this underway, and a few other people are going to join later. There was a little bit of change in the way we do this, I think requiring people a little bit to register, and I assume that also has caused a little bit of some delay for people trying to rush to join, but they will join us as we start. So today we are really so much excited to have Dr. Kamya join us. But before that, I want to remind you about the purpose of this CFAR seminar series. The CFAR seminar series meant to provide us a forum for presenting and discussing state-of-art research findings in HIV pathogenesis, virology, care, and treatment, and provide an opportunity for ongoing enhanced communication and multidisciplinary collaboration among HIV/AIDS researchers across the 5 CFAR affiliated institutions and their partner organizations. So in today's talk, we are privileged to have Professor Moses Kamya to talk to us about advanced HIV disease and mortality in the era of test and treat. And Professor Kamya is a professor of medicine at Makerere University in Kampala, Uganda, and is also the executive director of the Infectious Diseases Research Collaboration in Uganda. He has worked in the area of HIV care and prevention for over 25 years and heads the National AIDS Advisory Committee of the Uganda Ministry of Health. And as well, he's the co-PI of the large SARCH and CFAR trial in East Africa, which has done a lot of groundbreaking community-based trials to understand how to treat and prevent HIV. And I'm privileged to be Professor Kamya's students a couple of years ago at Makerere Medical School. So, Professor Kamya, you can take it over from here. We are excited to have you.
Thank you very much, Kenneth. I hope everybody can hear me. You can hear me well, Kenneth?
Yes.
Okay. So thank you, and good morning for those in Seattle, and good afternoon or good evening for those in East Africa. I would like to express my absolute pleasure for inviting me to give a talk of my interest. You know, the invitation was like open. So I really appreciate the opportunity. And in thinking about what I should talk about, I thought I should talk about advanced HIV and mortality. This is because I see this every day. I work on an ID ward and seeing patients with advanced HIV and perhaps dying in our hands. So I thought this was a topic that I should talk about today. Oh, sorry, it's not advancing. Or what has happened?
You want to click one time into the presentation to activate it, and then you'll be able to use your arrow buttons to advance the slides.
Okay, yeah. So yeah, I think it has worked. So yeah, I wanted to start with some historical aspects. This is the outline of my talk. You know, having lived for a long time seeing HIV before heart and treating HIV after ART became widely available, I can't avoid speaking about historic aspects of AIDS mortality, the time when we used to see a patient today and they are dead tomorrow. So I'll talk about that and the significant progress that we have made so far. So we've made a lot of progress in decreasing mortality, but there's still much work to close the gaps. I'll talk about the high burden of advanced HIV disease at population level and at hospital level where I work, and then move on to talk about the surge intervention, which we did and reduced HIV-related deaths. Then I will summarize and conclude. Now, this is how we define advanced HIV. It is the presence of any one of the following: either CD4 count, a patient presenting with CD4 count less than 200, or WHO stage 3 or 4 disease, or all kids who are less than 5 years old. And this is because children have increased risk of disease progression and mortality. So every child below 5 years is considered to have advanced HIV disease. Now, historically, some of you have seen this slide somewhere, somehow. You know, AIDS mortality had devastating impact on countries, communities, and families. In Uganda, in some of the districts, which some of you know, we had houses that were ravaged. So in this house that I show here on the right, these are all orphans. The parents had passed on, and you know, the children were looking after themselves. So over 20 years ago, about 20 years, but slightly over, we reported 2 million Ugandan children who were orphaned by AIDS, and an additional 1 million children who had parents with HIV. So HIV really had a devastating impact on us in Uganda as well as other countries. But I'd like to say before I forget that I'm personally very, very grateful to the US government, the PEPFAR, the Global Fund, to being in the clinic and seeing people die. Right now, when you come to our clinics, people are just looking very healthy. And this is because, there was a response, a very big response to providing ART to these very sick people who were dying. So many thanks to the US government and US taxpayers for doing this. Now, this is a slide from UNAIDS showing how we are doing on mortality. As you can see, we had a peak when we had about 2 million people dying. And then right now it's about 1 million. And then of course, we are not likely to hit the target by 2025, the UNAIDS target. But at least, it's decreasing, and certainly there's work to do, but there's a lot of progress. Now, I wanted to show this slide. Again, it is a UNAIDS slide showing that Eastern and Southern Africa is where AIDS is concentrated, and that is where the deaths occur mostly compared to any other region. 280,000 deaths in 2021. So Eastern and Southern Africa is really an epicenter of HIV. So in 2015, WHO recommended that all people with HIV start ART, irrespective of clinical immune status. But HIV-related mortality in clinic-based cohorts has fallen with scale-up of ART, but still, as I said before, 1 million persons are dying each year, which is unacceptable. In Uganda, it is 17,000 people. That is our statistic, dying every year because of AIDS. So in this day and era of test and treat, we would like to make that figure look less than that. I mean, we still have a very big number. It is unacceptable to have 1 million people or even 17,000 dying in one country each year due to AIDS when we have treatments for this disease. Many HIV-associated deaths are among late presenters. People present late. These late presenters, some of them are undiagnosed despite low CD4 count. They're out there in the community and are not diagnosed. But very, very importantly, some have been previously diagnosed, but either have not linked or maybe were linked and then defaulted and were lost to care. So we have this big group of people, either undiagnosed or maybe have been diagnosed and then have failed to link for some reason or have defaulted. So reducing HIV deaths requires that we have strategies to identify, to test, to link, to retain this challenging population. This is a very challenging population because the people who would come for testing have already come. So this population of people who have not tested or who failed to link is really a challenging one. So it means we cannot use the same strategy for people who would come and link and take the ART and remain in care. Now, I would like to show this. We talk about the first 95. Of course, I mean, as we all know, the UNAIDS target is of 2025 is to have 95% of people tested for HIV, 95% of those tested being put on ART, and out of those on ART, 95 getting suppressed. But I would like to focus on the first 95 testing people. Now, one of the key things about advanced HIV is trying to understand what happens to people when they test. Some people with an HIV diagnosis test multiple times because, they are never satisfied that they have HIV. They still have some doubt. So they remain out there and keep testing until, at some point they get convinced that their HIV status is confirmed. So in the meantime, they are delaying linkage to treatment. Now, others retest after disengagement. There are many people, at least in Uganda, who disengage. They say they are cured, they say they are well, and then disengage. And then when you retest them, then you were able to link them to care. So there are many people who need retesting just for the outcome of re-engagement into care. And among those with HIV who know their status, an increasing proportion of people testing positive have recently received an HIV diagnosis. So this slide was really meant to show you that when we go to test people out there, it's not only those who have never tested, but there are many people out there who are doubting their status, who need confirmation, who need to be re-engaged. So testing serves a lot of purposes, as I have outlined in this slide. Now, I'd like to show you some of the data from our Uganda population HIV impact assessment that came out recently. This is a national representative sample of adults aged 15 years and older. They are selected from 313 enumeration areas from all over the country. And so this is a national representative sample. And what do we learn from this? This slide shows adults aged 15 years and older diagnosed and, who have been previously, sorry, I can't see, so let me see. These are people who have had previous testing, and I want you to see what I've been talking about. So when you go out to test in the community, you find people who are completely unaware of their HIV status, and that is the blue one. So these are unaware of their HIV status. But there are some people who are aware of their HIV status and are not on ART. So they are also there. And then there are people who are aware of their HIV status and are on ART. Of course, that is the majority because we've made a lot of progress. But remember, some of these people who know their HIV status and are on ART can actually go back into being aware and not on ART. So we've got some kind of fluid situation here where we have some people unaware, some people aware not on ART, and some people disengaging. And so it's kind of a fluid picture. So I wanted down here, I think you can see unaware is 19%, aware of HIV status and not on ART is 3.2, and aware of HIV status and on ART 77, just to give you a picture of so this is a slide again from our UFIA Uganda 2020, and I wanted to show you a few things on this slide. First of all, we did CD4 cell counts on people. Now, on the left side of the slide, you can see that men, now these are people who are undiagnosed. So these are people who are not diagnosed. So among those, men who are undiagnosed, as you can see on the right, are more likely to have lower CD4 counts than the women. You can see the average CD4 count for men is 472 and for women 636. Those are among undiagnosed. And then if you look on the right, you can see the CD4 count, the percent distribution of CD4 cell count among undiagnosed people living with HIV. Those who have less than 200. Now, again, this is remind you, this is a population-based sample. So these are people who are not diagnosed. And out of those, 8.9 have less than 200 cells. And then you can see the distribution, 200 to 349 is 25%. And then, of course, the majority are more than 500. But as you can see, a large number is less than 500. And again, if you look at less than 350, although it doesn't define advanced HIV, but certainly less than 350, somebody is on the decline and they can quickly go into the bracket of less than 200. So you can see that maybe about over 1/3 of people have less than 350 cells among those who are not diagnosed. Now, I would like to show you some data from the hospital where I work in 2 hospitals. One of them is Mulago, another one is Chirudu. Both of them are within Kampala City. And I would like to show you some data on inpatient mortality and 1 month after discharge. These data are not published, but just wanted to give you some picture of what we see. So the study site is Chirudu. This is a smaller hospital than Mulago Hospital, but it's big enough. This was between March 2020 and September 2021, and we just had only adults that are admitted to the ward that I work. Now I wanted to show you like those patients that we admit, looking at over 3,000 patients. The median age is 39, and the patients we admit, their median admission. Those who are active on ART is slightly over 2,000. ART naive, like close to 600. And the ART, the defaulters are 778. You can see the percentages just here, 60%, 17, and then the defaulters. So you can see that the people we admit with advanced HIV, not all of them, some are naive, some are defaulters, but some are active on ART. But I'd like to tell you that most of these people, although I'm not showing the data here, but most of these people have only recently started their treatment. So maybe they have not had an adequate time, to have immune reconstitution. This is a distribution of the spectrum of opportunistic infections in our patients. As you can see, TB is number 1. I'm sure everybody knows that TB is our number 1 cause of admission in advanced HIV, and cryptococcal meningitis, wasting, and you can see the spread of all the others. If we go to comorbidities, did I skip a slide? If you go to the burden of comorbidities here, we have a lot of sepsis, but you can see also that a number of people with advanced HIV also have, many other things, diabetes, kidney disease, hypertension, and all of those comorbidities. Now, these are the outcomes at discharge. As you can see, about 26%, not about, but 26% died on the ward. We were not able to save them despite our best efforts. So we discharge about 2/3 of the patients alive. But you can see very many die when they are still in hospital. Now, I would like you to look at 1 month post-discharge. And, when we, among the people we've discharged successfully, when you go back 1 month after, only 61 are active in care, meaning that some people are not active in care. But 13%, now remember, 26% died in hospital, but now out of those that are discharged, 13% die within 1 month, and some others get lost to follow up. So I think we need to do a lot of work, to follow up these people and relink them to care. Of course, some, when they go back home, they don't relink. They don't go back to their primary health care, to their primary, primary hospital where they were referred from. So we have to do a lot of work to relink them to care. Now, let me switch gears and talk about our SAARC study. We have been doing SAARC since 2013, and the data I'm showing here, no, not the data, but what the slide I'm showing here is to show the overall aim, the overall goal of SAARC is how can we reduce HIV incidence and improve community health. We did SAARC in both Kenya and Uganda. The map is shown there. And the data I'm showing here is between 2013 and 2017, when we did SAARC. We call it SAARC phase 1 in 32 communities. And we were asking the question whether test and treat with the universal ART using a multi-disease patient-centered care can reduce HIV infections and improve community health compared to country guideline approach. So that is the SAARC phase 1. We use a multi-disease model, patient-centered care, and we are aiming to reduce HIV incidence and improve the overall health of communities. I think, let me move down to this slide. Now, for this study that I'm going to share, it was focused on patients or participants who are the CD4 of less than 350, close to being advanced HIV. So I just remind you, in the control communities, we did baseline HIV testing as well as in the interventions. So in both intervention and control, we did baseline HIV population level testing. But then in the control group, we did transport vouchers and standard of care. Now, in the SAARC or in the intervention group, we did the same as we did in the control group, that is giving transport, but we also gave a warm hand, a welcoming environment, and training our clinicians in addressing barriers to care and, giving a flexible treatment of patients depending on their needs. So some of the, we gave a multi-component intervention, including rapid ART start, viral load testing, welcoming environment, as I said, a warm hand, flexible clinic hours, mobile phone reminders, and things like that. So a number of interventions to sort of reduce HIV incidence and reduce mortality, we had a number of outcomes. So in this specific analysis, we evaluated the impact of the SARCH patient-centered care delivery model on 3-year mortality in the context of population-based testing. So again, our specific objectives were to describe the extent to which population-based testing identified low CD4 count individuals and estimating the effect of streamlined care on mortality among low CD4 counts. So we did, we ascertained mortality through a comprehensive key informant interview at year 3, and we classified deaths, in broad terms. Either you've died of illness or childbirth, suicide, or accidents. So this is the statistics. I think since these slides will be shared, I guess people can look at the statistics that we used, very rigorous statistics. Now, these are the results. It's not all the results, but some of the results. So at baseline, we had 143,000 stable residents aged more than 15, and then we managed to do testing on 91% of them, and then 10% had HIV, and 22% of those who had HIV had CD4 count less than 350. And then if you look on the right side, 43% of these people who had less than 350 were ART naive. Now, this slide shows that if you look on the right, for example, you'll see that we have a higher percentage of HIV positive men who had low CD4 count and were ART naive. Again, we have a problem of men more than women. If you see here, 34% of men compared to 20% of women had CD4 count of less than 350. And if you look at CD4 less than 350 and ART naive, it was 15% of men and 8% of women. So men are more likely, to have low CD4 count and to be ART naive, in this population-based sample of SARCH. Of course, it is illustrated in this on the left as well. 20% of women compared to 34% of men. Now, if you look at this, our intervention reduced mortality among low CD4 patients. So mortality among low CD4 HIV-infected persons was reduced by 28%. It was 28% lower in the intervention compared to the control. I mean, you can look at the overall, but you can see that the effect was much more pronounced among men compared to women. You can see the risk ratios here, 0.61, and the confidence intervals, but it wasn't statistically significant for women, the reduction in mortality. What did our intervention do? Our intervention accelerated ART start among ART naive patients. When we offered this intervention that I've described, you can see that the intervention had, they were more likely to start ART faster compared to the control group. Now, if you look at men trying to do gender differences, men were more likely to be aged 50 years and more, so they were more likely to be older. But even more important, men were more likely to have a CD4 count less than 150. So again, like I showed in the population-based sample from UFIA, when you go out in the population, there are more men who have low CD4 counts, and there are more men whom you can save than women. So there are these gender differences. So in summary, our such study, we did population-based testing, and we think that population-based testing reached many HIV-positive, ART-naive, low CD4 counts, and HIV-positive men were more likely to be both low CD4 and ART-naive. And after community-based HIV testing, such streamlined care accelerated ART start and reduced mortality by 28% among HIV-positive persons with CD4 less than 350, but particularly among men. And the higher baseline viral load and lower CD4 count among men not in care compared to women may place them at an elevated risk of HIV progression and death. So finding, as I conclude, finding low CD4 count people living with HIV in communities presents an opportunity to prevent HIV-related mortality. It is possible that some of these people, we may never get them unless we move into the community, either by doing population-based testing or finding, some ways of going out and finding where they are. Of course, it's not always the case that we are able to test populations in the way that we did, but certainly this is one model to reach this challenging population. So streamlined care, including patient-centered approaches and rapid ART start, was associated with 28% fewer deaths. So you can reduce deaths by doing some of the things we did in streamlined care and starting ART as soon as possible. So test and treat strategies could play a key role in meeting the UN goal of eliminating AIDS deaths. So thank you very much. I wanted to show you a photo of how we do such. When the rains come, it becomes very slippery. So you can see a lot of men here trying to push the car up the hill because we are working out there in the communities. So I want to stop there. And again, thanks for the opportunity. I wanted to sort of highlight this, not just reducing HIV incidence, but we should also focus on reducing HIV-related deaths. We've come a long way. We've reduced deaths by a significant amount, but we are still left with some work to do because our wards are full of people who are going to die of HIV when we have ART available. And even in the populations out there, there are people who will never come to test, or people who have disengaged, or people who are still doubting that they are HIV positive. So we need to do more work to close the gaps in order to eliminate HIV. So allow me to stop there and turn it over to the chair. Thank you very much.